Everyone, welcome to the 2021 Cigna Innovation Challenge Pitch Day. I'm Stephen Collins. I'm the CEO of MATTER. We are a healthcare technology incubator and innovation hub built on a core belief that collaboration between entrepreneurs and industry leaders is the best way to develop healthcare solutions. Since early summer, we've been working very closely with Cigna on a program to identify and accelerate transformative diabetes solutions. Cigna is a household name, but they are a global health service company that traces its lineage all the way back to 1792. Company today is number 13 on the Fortune 500 list with 74,000 employees, more than 185 million customer and patient relationships. And the question that we've been focused on together is this: how might we empower more people living with diabetes to reach their optimal health through supported lifestyle choices while navigating external influences? We put that question out to the world. We received applications from 9 different countries and chose 12 startups at various stages of development to participate in a month-long incubator. Each company has been paired with a mentor from Cigna. They've worked closely with Cigna subject matter experts, and they've participated in workshops and programs hosted by Cigna and MATTER. Today, we will hear from each company about what they're building, what makes them unique, and how their solution advances health equity. Each company will have 5 minutes to present, followed by 7 minutes of Q&A with a panel of judges from Cigna. And then at 5 or 6 companies will ultimately be selected to advance to the accelerator portion of this program, a 6-week phase where they will focus on exactly how they would collaborate with Cigna if they are ultimately selected to do so. And just set expectations, the judges will not be selecting which companies advance today, but rather will announce those decisions next week. So before we meet the companies, I want to turn it over to Dr. Glenn Stetton, who is the Chief Innovation Officer of Evernorth, which is a brand and a series of organizations that Cigna launched just last year to accelerate the delivery of innovative and flexible health service solutions. So Dr. Stetton, I turn it over to you.
Thank you so much, Steve, and welcome everyone to the Cigna Innovation Challenge. And thank you all folks at MATTER for running this diabetes program for us, very important. I'd also like to extend some appreciation and thanks to all of the Cigna mentors for their dedication to the project and the mentorship of the startup companies. And thank you, Cigna judges, for taking the time to review and judge today. And then James, Audrey, Mimi, thank you for your leadership from the Cigna and Evernorth side, for your leadership for the program. And thank you, all of you startups, for the time and effort that you've put in to engage with us. It's really important. And I thought I'd just take a moment to remind everyone, why are we, Cigna, Evernorth, putting on this innovation challenge? And it is to solve their big healthcare challenges for people living with diabetes. And also, if you think about us as Cigna and Evernorth as partners for you all, it's for solving the challenges and big challenges for diabetes that are the challenges for the plan sponsors and the plans that pay for diabetes care. So let's take a minute and I'm going to share some thoughts about how we think about the biggest healthcare challenges for people living with diabetes. One is, right, that they not be defined by their diabetes, right? Diabetes may be something that they have, but we need to think about how to make their lives easier. It's hard and complicated living with diabetes and keeping your diabetes in check. And really what people want, right, is a long, healthy life where they don't have to think about their diabetes every day, and preventing the symptoms and complications that affect their health long term. And it's really, really hard to do. And it's especially hard for people who come from communities that have been socially disadvantaged. And part of the reason that we emphasize the importance of health equity in the challenge. And then let me not forget that it's expensive to have diabetes. The medications can cost a lot of money, as well as complications. And then let me talk about the health plans and plans that pay for the care for a minute, because first and foremost, we need to think about human-centered design and what we need to do for the people who live with diabetes, and that's where our empathy needs to be. But for the plans that pay for diabetes care, right, they're really interested in affordability of that diabetes care, not just for the people who have diabetes, and that's really, really important, but also for the affordability of health insurance, because people with diabetes and people with any serious disease, right, by and large, they consume health plan resources at a significantly higher rate than they're represented by their numbers in the population. And that's what insurance is for, right? To help people with their expenses. But when we have very, very significant cost areas, it threatens the affordability of insurance for everyone. Health plans are very interested in quality care and outcomes and preventing complications, but also in simplifying the experiences for people in interacting with the insurance company, and also for the care that they seek. And then lastly, it is certainly important to us, and it is important to our clients, other health plans and employers and government, that we address the issues of health equity. And for diabetes, it is a significant problem in our country, and it is a worse problem in terms of higher prevalence and higher rates of complication for healthcare outcomes for people of color and people who live in socially disadvantaged communities. So let's talk about why programs like this are important, and important to how we innovate. And the key thing for me is that we've asked everyone to take an outside-in perspective, right? Think about the problems from the point of view of the individual who's living with diabetes. What are their problems that we need to solve, and focus on solving those problems, as opposed to thinking about what we internally need, right? We will figure that out. The first part is to get it right, get the model right for the people who have diabetes. So with that, let me wish all of the teams good luck in the challenge. And again, thank you for being part of it. And I'm going to pass it back to James to introduce the judges.
Thank you, Glenn. Some great words, and really a great way to set up for what we're going to hear today and the importance of this challenge for us as an organization. I am honored to introduce our judging panel today. They come from across our Cigna and Evernorth organization and represent a number of different disciplines that will be able to bring a great perspective on the different solutions that we'll hear today. So with that, I'll introduce our panel. Dr. Zach Goodman, Clinical Innovation Director in Evernorth. Wendy Tan, Senior Director, Enterprise Strategy. Sandra Bello, Health Equity Manager. Richard Antunes, Senior Clinical Consultant, Express Scripts. Nico Koning, Senior Associate at Cigna Ventures. Mimi Bright, Product Strategy Principal, Diabetes Care Management Solutions. Heather Blackhay, Clinical Program Senior Advisor. Erin Brawler, Customer Experience Design Lead. And last but not least, Audrey Wesson, Design Lead, Disruptive Solution Design Team, Evernorth Innovation. We're excited to have this great panel who will be with us throughout the day asking questions of all the startups. With that, I'll turn it over to Sabrina and we'll get the program started.
This is a really, really great group of startups, cohort of startups, and it's been amazing to work with this Cigna team that is always willing to give their time. So we really thank everybody that has participated in this program, and we're really excited about today. So with that, let's get started. I do want to note that for the startups that I will be interrupting you if you go over time. No hard feelings in advance. And our first startup of today will be Clinio.
It's my honor and pleasure to start this. So hello, everybody. My name is Oshirina, and here you can see me and my grandmother smiling at you. 7 years ago, she was diagnosed with type 2 diabetes. I remember well how stressed and overwhelmed she was. There was one thing clear to her and the rest of the family. She needed to change her bad habits, set new routines, and starting from the simplest, yet the most powerful one, how she should change her eating habits, what she should start eating. We created Clinio with a mission to create the most engaging and effective diabetes management program that promotes self-care and empowers people. So instead of leaving them alone to deal with their condition, we give them a framework that it has a power to customize every step of their journey and truly take control of their life. And the best proof that we hit the nail with our product is our continuously growing customer base. Currently, we have more than 170,000 active paid subscribers. And they choose us and stay with us because Clinio is simple to use. They can find everything in one place. It is fully customizable. And most importantly, we personalize everything what we do, from the way how we market and target our customers to the way what kind of notifications and nudges we send to them. Program is based on 4 main aspects of diabetes management: nutrition, physical activity, education, and community. We're extremely happy to have an extensive dietitian team who created a huge database of various recipes. Now we have roughly 45,000 unique recipes. Our users can select what kind of food they like, if they have a certain allergies, to truly get a personalized meal recommendation. Personalization is also key when we approach daily tasks, habits, and education. And again, customers can select how often they want to track certain vitals, when, how they want to approach education. Of course, we give some default setups and recommendations, but again, we really want to empower our users. Now, our new approach regarding community, making it even more engaging and appealing, is that customers first, they take the picture of their food, they evaluate themselves, is it healthy or not, and then share this with broader community and receive feedback. Conscious eating is very important, and I truly believe this can change the lives of our customers. We are meeting our users in their preferred way. So our program can be found as an app, also as a web application, and even in the printed form as a book. Besides English, we support 7 other languages. Again, we truly speak the language of our customers. If we dive deeper in our user base here in the US, we have above 120,000 active users. Roughly 60% of them have type 2 diabetes and 30 pre-diabetes. And again, here we really try to help our customers even to prevent diabetes, not only help to manage the condition. Seeing that we have older generation, we include that in the way how we develop our product, even from small things such as button size. One of the key things that talks about the success is our engagement numbers. A few of those that I want to bring is the time that user spends per session. So on average, they are spending 13.6 minutes and using at least 1.7 times during the day. That means that really they love and appreciate the content that we are giving. When we look at HbA1c, again, we're collecting 0.4 entry within 6 months, and we're encouraging our customers to check their sugar under control. When it comes to outcomes, we are super happy that 50% of those people who already reported initial weight loss, they stay on that track for 3 months. And after a year, on average, they lose 7.3 of their body weight, which is an incredible result. At the same time, they also are able to reduce their HbA1c by 0.5%. The last element, just to say, that we have partners who help us to validate these results as well. When it comes to our own growth, from the year we started, we doubled the users. We plan to keep the same pace, working a lot now to expand the community, coaches, and including mental well-being module. At the same time, opening new sales channels and working with self-insured employers and health plans. So extremely happy to participate here at Cigna Challenge. And if you need to remember 3 things about Clinio, it is that it's personalized, it is easy to use, it is supportive, and we bring all the things that a person with diabetes need to manage their condition and be in control. Thank you for your time.
Thank you so much, Osreen and Clinio. We really appreciate your time and effort. So right now, I'll ask all the judges to please come on camera. and to ask Clinio if you have any questions.
I'll start. Question, I noticed on your roadmap that you had adding mental health and mental well-being in your roadmap. Does the app now incorporate physical activity, or are there plans to add that as well?
It's already included. So our customers get easy workouts where no equipment is needed. So we encourage them to be a bit more active.
Okay.
That's already there.
Great. And is there any connectivity to devices? In other words, whether it be a CGM, a Fitbit, or a connected scale as well?
Yes. So our users can connect with blood glucose monitor devices. We already cover a majority of them. We also have integration with Fitbit and other step tracking devices. So yes, this is very important that we would reduce that unnecessary step for our customers, and the data would go synchronously.
One other question in terms of health equity, I noticed that you translate into 6 languages, which is great. In terms of searching for the recipes, can somebody search by certain ethnic or desires? If they like Latin American food, if they like Asian fusion food, can they search by a culturally competent recipe?
So one thing what they already can do is identify what kind of food items they prefer. For example, if they would like more beans to be included, then when they get their personalized meal, if they don't like certain choice, they can skip that meal and select from additional 10 options. And it is on our roadmap to include the selection that you could filter by certain cuisine. And as I said, we have 45,000 unique recipes, so there's plenty of choices. So that's a very good question. Thank you, Mimi.
Thank you.
Hi, good afternoon, Richard here. To follow up on Mimi's questions, so devices can connect to your app and stuff, but does the data go anywhere else? Can it connect to Teams for personal support?
Do you mean like, for example, sharing the data with doctors?
Yes, yes, exactly.
Yes. So yes, so user can generate a report that later can be printed or shared.
Okay, great. And a follow-up to the language and recipe translations too. Is it just a natively language translated, or do you also work on kind of culturally translating the content as well?
Yeah, so naturally, the first step was first of all to translate by using the local language speakers, and they also help us to make sure that we are culture appropriate and really speak the language of our users.
Okay, thank you.
Good morning. I want to ask you a question. You mentioned that right now you work with health plans and employers for the solution offering to the market. Do you have any plan to go direct to consumers?
So currently our business is direct to consumers. So all the clients that I mentioned, 170,000, they are direct users. And from this year, we not shift necessarily, but expanded the focus and started to think about self-insured employers, have the first couple of pilot clients planned and participate here at the competition. But we really learned a lot from our huge customer base. It enabled us to test and iterate quickly. We are adding small tests and tweaks to our product once or twice per week. So this really helps to make sure that we're increasing their attention and engagement and trying new ideas. And getting the real feedback from a broad audience.
That's the case. As a consumer, do they have to pay to use your app?
Yes, it is subscription-based model. So they have to pay. And again, this even raised the bar even more for us to make sure that the product is top-notch and then we deliver on our promise.
All right, thank you.
Okay, thank you so much, Asreen. Thank you, judges. Everybody could go ahead and go off camera.
I think I just wanted to thank you for great question and great support during the competition.
Thank you. Okay, awesome. Next up, we have Snack.
Yeah, hi everyone. My name is Aurelian. I'm CEO and co-founder of Snack, and I'm very happy to be here today and tell you more about Snack. So there are millions of people living with diabetes who face significant challenges around every meal. So if you look at the meal on the left, if you're living with diabetes, you will ask yourself, okay, how many carbs are in that meal? And somehow guess on how that eventually impacts your glucose levels to then avoid spikes or even serious lows after the meal. And all that because it really matters on the one hand side, on the short term, as well as on the long term in terms of your health. And that whole guessing and uncertainty leaves many people with diabetes that they actually enjoy food much less than they used to do without diabetes, because it's so much about planning, it's about numbers like carbs, it's about checking like glucose levels all the time. And we want to remove with Snack some of that guesswork and some of that uncertainty to help provide more guidance towards personalized and data-driven decisions around meals. That ultimately, people living with diabetes are again able to have more peace of mind around meals, more freedom and more joy to go out and have more flexibility. How we do that? We've developed an app called Snack, where you can very simply snap a picture of your meal to get nutritional values. And it's doing that so with our patent pending image recognition technology, which tries to automate as much as possible, including portion estimations. And then we allow you to connect and automatically and seamlessly import data from over 20 of the most popular diabetes devices. So whether it's our glucose sensors, insulin pens, insulin pumps, and so on. So that the data then can be visualized in the context of the meal, again, in a very simple form to let you see on how that meal impacted your glucose levels. That works for CGM as well as for BGM devices. The ultimate goal is really to provide you the insights where you can learn and see what worked well in terms of your time in range and what eventually worked less well to rather avoid in the future. So where we are today, we have close to 14K users on our app with a very good App Store rating. We have a 10x better retention than average health and medical apps out there. We're currently growing our direct-to-consumer subscription revenue with 40% month over month. And we have first data on actually really improved outcomes on postprandial time in range after using Snack. So what are some benefits we can bring to B2B partners? It's, we believe, the simple visual and self-explanatory approach of our app makes it really accessible to people with different backgrounds so that it's understandable and it brings the message across through that simplicity. And additionally, we today support free languages and you can use it with many types of different foods. So it respects, so to say, the personalization of things. But last but not least, the most important thing is that the solution is actually out in the market and it's being used with many people every day. And we have first data on the benefits of using it. So the founding team is from a rather product management and technical side. And from the advisory side, we're supported with many well-established people from the diabetes field. Particularly, I want to highlight Dr. David Kerr, who with Samsung Diabetes does a lot on health equity with his Farming for Life, for example, for Latino populations. And to highlight just a few things on our ambitious roadmap ahead to grow to 1 million user base, we'll very soon release a community functionality which should bring people together and support them on their journey towards even better health, because eventually within their own community, that support might not be always there. And we really want to bring the positiveness of a community as a next big feature actually to our app very, very soon. So happy to tell more on what else we've planned beyond that. And I would also be very happy to have you part of our journey to bring that life-changing solution to 500 million people living with diabetes. Thank you.
Thank you, Aurelian. Very wonderful presentation. All right, we're going to just keep with our super fast cadence. So can the judges come back on camera? And Aurelian, can you stop sharing? Perfect. And fire away, judges.
Oh, hi. Good afternoon or good morning. So are you able to also predict the response? So let's say, someone scans or takes a picture of a meal, right? And they've maybe had it previously before. How does, is a person aware of like, hey, what will this actually do to kind of my glucose levels?
Awesome question. It's actually still part of our Q4 roadmap. And it's not directly prediction what we will do in the first step. It's actually telling you, we have already something like similar meals, but we'll take it one step further and tell you based on similar meals, your time in range was so and so. Basically, that allows you to guess whether it's usually rather high or usually rather low, or it's in range. So that's the first step, and then we'll move on.
Got it. That makes sense. And in terms of, for example, drinks, like if somebody, repeatedly drinks, soda or, Starbucks caramel macchiato, something that's kind of, bad for their maybe glucose levels, how do you think about capturing those?
Yes, so there are two ways to capture it. One is with the image and one is also without an image, basically like a regular logbook. And so both of those, in a way, you can record it.
Thank you.
Thank you.
In terms of continued usage, people who are signing up, tell me about the longevity, how long somebody sticks with using SNAC. Does their frequency of taking the pictures increase, decrease? Tell me about sustained behavior and how that works.
Mm-hmm. Yeah, over like several months, basically it stays at around 40%. So, that's now talking about the people who have the glucose data in there, either BGM or CGM data. So yeah, that's a really, really high number. It's, as I said, like about 10x better than the average app. And in terms of the usage frequency, I would need to check on different metrics on that. I'm happy to get back later.
Okay, thank you.
Hey, good morning. So I have a question here. Say I'm a patient and I can't afford CGM or barely BGM or my basic insulin. How can this help me?
Mm-hmm. So yeah, it basically then a lot of the functionalities are not available, but then there's still the functionality of a usual logbook, which is very visual and very automated in a way to still get to the nutritional values there. But our belief is strongly on the personalization. So we somehow prefer to have that loop to be able to tell what worked and what not based on the glucose response. But there are many people actually also using it without the BGM and CGM. So there seems to be, even for that, enough value for people.
Okay, and have you done any testing for patients with lower health literacy or lower numeracy skills?
Not that we have studies on that, unfortunately, but what we continue to just receive as general feedback is that it's very simple, like very clean UX. So we hope that would help for that as well. But unfortunately, we don't have direct data on that.
Okay, thank you.
I have one question. This is Sandra. My video is not working, so I apologize. I know you mentioned that the demographic background is diverse and there's personalization. How many languages does it support? And then does it also recognize the different cultural foods when you take the picture?
Thank you for your question. So currently we support 3 languages. So the whole framework is set up and it's relatively easy to add additional languages. And then in terms of cultural foods or foods from different regions, it has a self-learning algorithm and the personalization part inside the algorithm to actually cover for that. So if our app starts to be used more within a certain population, it will automatically adapt accordingly in regards to the recognition of the different foods and the suggestions it makes.
A quick question. Can you share how you currently acquire customers? Do you directly go to consumers, or you go through a health plan, employer group?
Yes, actually similar to the speaker before, currently we're direct to consumer, and we've made very much the same experience that needs to keep us very focused on the value and we provide and the learnings we can do very, very quickly. So currently we acquire all our users direct to consumer, but we also see part of our journey to evolve into various B2B collaborations to make it accessible to even a broader audience.
Okay. As a consumer, in terms of price point they're paying for this app, is it free? Is it, what's the price point? Or you can just say general compared to other similar solutions on the market, is your price point high, medium, or low?
Sure. So we run on a freemium model. Some features are free, others are not. I would say we are medium to low. Particularly if we go on a yearly plan, it's rather on the low end. Monthly, it's probably mid.
Thanks.
Thank you. Thank you very much for all the questions. I'm happy to be available for further questions afterwards by email or however.
I do have one question about your actual tech there. Any ways to detect like hidden calories? You know, am I a person who likes to cook with butter or oil, or skip that part?
Hidden calories. Okay, sorry.
Yeah, like hidden calories, depending on my cooking style, right? Like, am I a person who likes to use sugar in my baking, or substitute with applesauce, or you know, am I using lard or butter or margarine? So
purely from an image, it's impossible to recognize. Actually, we did some comparisons with RDEs as well on that, and it's possible for not even for humans.
Yeah.
So currently, we don't point that out specifically, but it would actually be something to consider for our roadmap. So I really appreciate it.
Yeah, and I guess in my mind, I was kind of thinking maybe you ask like questions if you're cooking it, or you know how it is sometimes, like if you get mashed potatoes at a restaurant, it's really just a vessel for butter versus making it at home.
Yeah, we currently don't. I mean, you can enter it. You can like enter it these pieces, so to say, but we don't give specific recommendations on it currently.
Okay, thanks.
And we will now move to ECHN.
So good morning from Manchester, Connecticut. I am Katie Gustavson, the Diabetes Program Coordinator at Manchester Memorial Hospital. I'm also a registered dietitian and certified diabetes care and education specialist. And what we've developed is diabetes literacy for all. It's a massive movement to embed diabetes literacy into healthcare systems, culture, and community by engaging patients, families, providers, and their medical staff where they work, learn, and live in order to reduce the burden from diabetes and complications. Diabetes Literacy for All is one of the only innovative programs of its kind, and it's designed to help community-based clinicians and their office staff navigate the complex changes in the healthcare industry. Training, educational programs on diabetes management, along with resources, will be offered. And this is an individualized platform. It'll be in person, virtual, or online learning with modules that they can go at their own pace. The training team includes experts like physicians, nurses, dietitians, diabetes educators, and others. And the provider training program will be quarterly, and the medical office staff at baseline is a 2-hour training program, and of course, a follow-up with ongoing support provided. Resources such as infographics, flip charts, simple to read education handouts, which will cover at least 20 topics related to diabetes care. They'll be in both English and Spanish, but we're also investigating other languages to better serve diverse populations. These trainings and resources, they're going to address things like fear. As we know, fear is common among Latinos and Hispanics and others when they start insulin. One of the most challenging tasks is nutritional preferences, as each race and ethnic group has unique and preferred foods. the inability to consistently obtain foods, especially nutritious foods, so having resources to fight food insecurity, being mindful of patients' financial challenges, religion and faith, addressing things such as Ramadan, depression and diabetes, along with diabetes distress, getting familiar with alternate therapies and medicines like herbs and plants, and overcoming barriers to physical activity, as hair can be a barrier to regular exercise for some Black women. By working in tandem together as a multidisciplinary team, this will close gaps in fragmented care and reach the primary goal of the program, which is to improve patients' hemoglobin A1C levels. We know this is going to work because we've had provider meetings with 10 providers and 5 office staff managers within the system in order to gauge interest in the topics that we've presented here. And they're able to provide feedback into what topics are of interest and what's needed within their practice and have agreed upon the content. $327 billion is the cost the US healthcare system is paying for diabetes. We already know this. If the apps are an effective management tool, then you'd expect glycemic control to improve over time nationally. However, NHANES data shows in 2007, 57% of the US population had an A1C control, and this declined to 50% in 2008 to 18. Therefore, we need an effective tool that works. One can argue that the most important relationship is between a clinician and a patient. It's rooted in trust and benefits the patient. So how do we support the primary care physicians? We know it's not a lack of resources. There's plenty of apps and software, but asking an already overburdened physician to use them is unlikely. Older patients are reluctant to download apps, may not be tech savvy. I mean, hey, they probably still have some flip phones. Ask my dad. Those are underserved populations, may not have reliable Wi-Fi or access to technology. Meanwhile, they haven't seen the same physician for years. So with this program, we're going to be able to provide CMEs that are easily accessible. The physician can do it at their own time, because at their leisure, because it's going to be offered in various ways. Yes, we know the gold standard of comprehensive diabetes education programs are delivered by educators within the ADA recognized program. We know that's not realistic. The constant is 90% of people with diabetes are managed by their PCPs. The need for diabetes education in primary care settings is high, and it might be the only opportunity to get the information into the hands who need it the most. So instead of expecting patients to seek education outside their medical homes, the program will effectively bring diabetes information and services to them by arming their primary care practice with linguistically, culturally relevant information, and it'll positively influence the relationship with the patients. That patient-provider communication is vital, and patients' diabetes knowledge will directly improve their self-care behaviors. It's also going to mitigate the issues with transportation, scheduling, communication, and cost barriers with the patient. So by having diabetes educators in the healthcare system as a whole, that's going to give us an advantage because we have the secret sauce. We know these patients. We will bridge the gap by using a system and solution that works, and we know it works. Having diabetes education one-on-one at a one-on-one level works. As you can tell, I'm very passionate about diabetes education, and I appreciate the opportunity given to me today, and I look forward to collaborating in the future.
Fantastic. Thank you, Katie. Appreciate it. Okay, Katie, at this time, can you stop sharing your screen? And can I ask the judges to come back on camera? Awesome. I see your beautiful faces. Go for it. Anyone that has a...
Sabrina, I have a question. So when you talk about, you've talked about providers and patients and education, are you educating both the patients and the providers, or just working with the providers to educate the patients? Tell me a little bit more about how the education works.
Good question. It's a two-pronged approach that really reaches the patient. So initially, we will be going in and educating the staff, the medical office staff, the ones who meet with the patients, you know, on a daily basis, the CNAs, medical assistants, the nurses who have touch points with these patients, so they can talk a little bit more about this patient, feel more confident in the diabetes basics and giving them resources. Patients go in and see these people that have been seeing them for years, so they trust them. Also by going in and seeing their staff members, giving education to the providers where they need more information, such as, hey, I need resources in Spanish because all my patients come to me because I speak Spanish. keeping up with the rapid evolving pace of technology, whether it's webinars on CGMs or pump therapy, the new insulins, et cetera. So in turn, by arming them with all those information and resources, yes, ideally, I would like them to send them to diabetes education to my practice, but again, it's okay. We know that they're doing diabetes education in their office. Yes, some can filter down to diabetes education as a whole, so they can tap into their benefits of 10 hours of DSMT and 3 hours of MNT when they're first initially diagnosed. But again, they don't have resources, transportation, all those things. So therefore, we gotta give it to where they're seen the most at their practice.
Thank you.
I have a follow-up question, Katie. So how do you ensure the clinicians you educated already share the information with patients? Do you have any data or evidence to share with us? So far, X percentage information has been shared from the clinician to patient, for example.
No, just because of where we're at in our program development, though we have been having webinars and Teams meetings with our physicians and office managers, and I've spoken with 10 different physicians, and what they're asking for is additional resources on nutrition and exercise and having resources for insulin cost savings programs. Also, miscellaneous things such as, with COVID, a lot of patients don't have money to go and buy food. That's a huge barrier. Having access to food share or WIC or food stamps or other places in the community that can provide them food for free to be able to bridge that gap. So we are understanding what they need more information of so we can supply them. And that we'll be able to create and tailor and add more in as we see that they need that.
Okay, thanks.
Hi, Katie. Richard here. So I think I hear you where you're providing these providers, primary care, more resources, more things to help their patients. But one of the other things I hear from a lot of primary care is I just don't have the time. I've got so many issues, so many problems, so many things to deal with or to help this patient within 15 minutes. Anything to help the provider streamline this process and really focus on like the high impact?
Right. So a lot of these handouts will be kind of the quick one-offs. What is hypoglycemia, alcohol and diabetes, complications, DKA, sick day guidelines, carb counting. So then that way they can easily go to it, and we may be able to do it tailored, like here's English, here's Spanish, here's Chinese, here's Polish. So then that way they're all similar, giving the same created content, again, streamed down to lower literacy that they can provide across the board, where they can just say, at least here's some information that I'm giving you. So the patient feels seen and heard and will engage more in their care.
This is Minnie. Quick question. In terms of how your solution would compare to a traditional diabetes clinic or an on-site or a hospital program, what makes it different than others?
What makes it different than others? Mm-hmm. So I don't think many people are going out into the community and doing this type of education within their community to their physicians, and going to all these offices. A lot of times people are staying in their own lane, in their own niche, and doing what they can do and getting the referrals for diabetes education. But what we know is it's not working. By the time they get to us, I just had a woman come in here. She's been in for diabetes education 20 years ago when she was first diagnosed. Well, where have you been for the last 19 years? You still have DSMT and MNT to use that. It makes it different is because we're collaborating. There's such fragmented care, especially being on different platforms, seeing face to face, so they know us. We're working together as a team, and once people notice that we're working together as a team, they feel it's part of a community. When they feel part of a community, they're going to be more engaged. Did that answer your question, Mimi?
Yeah. Mm-hmm.
Awesome. We have time for one more short question. If any other judges have a question. Fantastic. Okay. Thank you, Katie. Appreciate your time and your presentation. And thank you, judges, for great questions as usual. Fantastic. Everyone can turn their cameras on. We are moving on. Next up is glucose vision.
So, good morning, judges. My name is Liam, and along with my longtime friends, Osama and Ashad, we have come together to present our company, Glucose Vision Inc. from Toronto, Canada. In middle school, I had a friend, Stephen, who used to prick his finger every so often. And at a curious young age, I once asked him why he always did that. And I remember he simply stated, "It helps keep me alive." And then as I grew older, I noticed my father doing the exact same daunting process. I would always hear him talk about how much of a struggle it was to keep something called blood sugars at a low level. And this is when I was introduced to this disease called diabetes. Turns out Stephen and my father were just two of the 34.2 million Americans that face this challenge every day. Through user interviews, we learned that 92.4% of diabetes patients struggled to manage their condition when they were first diagnosed. And the uncertainty of glucose level rises from foods patients eat can lead to 40% of patients developing one or more severe future illnesses. And the uncertainty of portion sizes leads to 50 to 60%. So our solution is a smartphone application that has the ability to analyze the patient's meal in real time to return an accurate carb count, display their blood sugar projection, and advise of portion size adjustments, all with the snap of a picture. We use machine learning and AI to personalize these factors to be more user-specific over time. So ultimately, Glucose Vision is reducing the chances for patients to develop future illnesses by creating the first smartphone application capable of pre-evaluating their meals to determine healthy portions and increase their time in range. So early adopters are patients and families of patients that have recently been diagnosed with type 1 diabetes, which is usually under the range of 20 years old and consisting of about 200,000 Americans as of last year. So once we build a foundation within this target market, we plan to expand to other markets such as the rest of type 1s, type 2s, gestational diabetes, and even pre-diabetes. So what's our underlying magic that gives us this competitive edge? Well, Glucose Vision is the only company that offers real-time portion analysis, displaying users an accurate carb count of the meal in front of them, and recommends on-the-spot portion size adjustments to help users minimize their blood sugar spikes. This is unique from all our competitors because it allows users to adjust their meals before consumption rather than finding out after with common post-analysis methods. Simultaneously, we take their blood sugar reading before and after the meal, so then we can reverse calculate what the carb content was. This allows us to provide a more accurate projection to the users if they eat the same food the next time. So our unique AI allows users to have a personalized carb count as everyone's body is different. Lastly, we are also the only company to offer a diabetes-friendly menu to restaurants and fast food chains using the user's location. So it makes it easier when they're all eating out. So we've been awarded 50,000 in grants and established collaborations. With the help of Professor Dr. Khan on R&D and our continued user input, we plan to have our algorithm fully developed by the end of this year. We'll also be looking to obtain technology patents for a Class 2 software as medical device category license for the algorithm. And with the network we've built from speaking with all these people, we continue to perform customer validation B2C with an app interface MVP and base algorithms that we've developed thus far to make sure we're always building with our end users. So for our premium release, we plan to work with an app development firm in March 2022 to help us finalize app UI and host a full data set of foods. And then as we continue to expand, we plan to target a B2B partnership with a large healthcare organization and become endorsed by healthcare professionals across Canada and the US. So prototype launch will be used to gather information from our early users and also make relevant changes to the app. So 6 months after, we'll be releasing our premium upgrade, which consists of $15.99 per month for the year and then $5.99 per month thereafter. So we plan to initially capture 2% of our early adopters shown through the channels on the slide. So that's through Facebook, social media, YouTube, all these ads to capture them. And once we have a strong customer base through validation, we plan to expand to the B2B relationships through partnering with the healthcare organizations and recommendations from health professionals, which can help us expand to different demographics every 6 months. So our application takes health equity as a great importance. For example, we know that given your different social background for various individuals, their foods they eat vary based on their ethnicities. So this is why we've made it a priority to train our database on over 100 ethnic foods to ensure usability across all demographics. And in addition, we understand everyone's body is different, especially when it comes to diabetes management. So this is why our application is driven by AI to personalize the application to the user over time. Join us as we explore a healthier life for diabetes patients across Canada and the US and all around the world. Thank you for the opportunity to pitch our company, Glucose Vision.
Thank you, Liam, and Glucose Vision. Fantastic. Liam, could you stop sharing your screen? And can I ask the judges to come back on camera? There you are. All right, judges, fire away.
Quick question on the, can you describe a little bit more about how you use the machine learning and if it applies to the insulin at all or just the carb counting?
Yes, so it applies to just the carb counting because a really important aspect is we want to always make sure we're still working with patients and endocrinologists and they're all given their carb to insulin ratio, and we want to make sure that's being followed and inputted into the application. So the machine learning comes more into the aspects of learning the types of food the patients eat to give more accurate carb predictions, or even for dissolved carbs that maybe aren't visible for an image. If we're able to take their blood sugar reading before and after, the application can then learn the blood sugar change and then give a more better estimate of what the carbohydrates actually were in that meal the next time it pops up.
Thank you.
Thank you.
I have a question. I love the in the moment recommendations that your tool provides. Do you have any data on how often those recommendations change the person's behavior or have them eat something different or less?
Yes, so we don't have enough user data to actually be able to make those claims right now. But a part of our application is it's sort of like we want to be able to log that after and sort of show the user like, A, did you follow the portion recommendation? And this is how your blood sugar responded. Great job. Or B, we realized you actually didn't follow the portion recommendations. And this is actually how your blood sugar affected you. And sort of giving them that data to know that they need to make the smarter decisions, the healthier decisions moving forward.
Thanks.
Hey, Liam, maybe if not, say a broad set of user data for that, any kind of feedback from early adopters where it's helped them change or adjust their behaviors, kind of hidden calories and hidden carbs?
Yeah, for sure. An example of like a lot of the reoccurring feedback that we have gotten is like current apps and also for our pricing model, we based off a more well-known one like Glucose Buddy, which a few of our early adopters have been using. And it's really that on the spot sort of decision time that they were missing, which is really why we wanted to make that a focal point. So these portion recommendations that we're able to give them on the spot, they think is very helpful than sort of learning after the fact, because even if they do learn, it's still on the user to make those decisions. We want to take as much load off the user as we can and make sure the app is presenting those decisions to them, which they really appreciate. So they're able to make those on the spot.
Okay, great. And any ability to say, if they're taking a picture of their food to calculate carbs and stuff, any ability to save those images they can review with a diabetes educator or provider later?
Yeah, 100%. And great point. Like every photo and every information that's taken is always being logged into the application, A, for them to review with a healthcare professional, and B, even a tab on the app for them to review on their own time as well, if they're curious on how all that's been going.
Great, thanks.
So with that, let's go ahead and get started with our next startup. Is Neep back from the break? Wonderful. We see your presentation, George, but we do not see you yet.
Hello.
Okay, there you are. Wonderful. Okay, take it away, George.
Brilliant. Hi, everyone. My name's George, and it will be my pleasure to introduce you to Neep. the diabetes management app that breaks down the psychological barriers to diabetes self-management. So I want you to imagine that you have a checkup with your doctor and your life changes forever. You've been diagnosed with diabetes and your blood sugars are at life-threatening levels. After diagnosis and several nights in hospital, you quickly realize that living with diabetes is all-consuming. There are no days off, and you complete 95% of the management yourself. You develop what's known as diabetes distress, which naturally leads to your health and diabetes management in a downward spiral. And this is something I experienced firsthand when I was diagnosed with diabetes 4 years ago. So after doing some research, I found there's a huge gap in care here. 7 out of 10 people feel overwhelmed because of the stress associated with the condition. 76% of people don't get the psychological support they need, and the barrier to support can be too high, with those experiencing acute distress not qualifying for any mental health support. And without support, unfortunately, this leads to further mental health complications, which is likely due to why you're 11 times more likely to take your own life if you lived with diabetes. And the gap in support stems far worse in minority ethnic groups, with 4 times the rate of diabetes distress being prevalent in Black African American adults experiencing the greatest burden from diabetes distress. Clearly, there needs to be a better solution for dealing with diabetes distress. So next, we worked to build a community to support us in co-designing a solution. The community now has 300 people living with diabetes and has a 60% return rate. Through surveys, we learned that 78% of people valued a diabetes community, and diabetes emotional health complications were also prevalent. We learned that the ability to log external factors such as stress and menstrual cycles would be valuable due to how these factors influence the way blood sugars behave. So with the help of the community, we got to work in building our solution. And our solution is NEEP. NEEP is a digital app that provides accessible, psychologist-approved practice to calm the waves for those living with diabetes. We cover 3 core features: a health journal and calendar to reflect and record your blood sugar and insulin intake. Users can also log other often overlooked factors like mood, appetite, sleep, and menstrual cycles as requested through the community. Secondly, we have a self-care hub to practice diabetes-specific meditation and psychologist-approved stress reduction techniques. And finally, a support chat. For those who are navigating through slightly bigger waves, we offer an on-hand diabetes psychologist, providing resources, one-to-one therapy, and live group mindfulness sessions. So NEEP offers several ways to provide diabetes distress support to those who need it most. We offer accessibility through different delivery formats and will be available in different languages once we launch. We are hiring a network of psychologists and mindfulness teachers who will be both competent in understanding diabetes and culture. And we reduce stigma by providing a supportive community with people who understand and live with the condition. So moving on to our competitors, our closest competitor is MySugar, who offers diabetes data tracking. However, they don't provide the functionality to support users in managing stress levels. And similarly, Ginger offers on-demand mindfulness practice, but it's not geared towards people living with daily diabetes management. And our team consists of Dr. Sophia Gard, our lead clinical psychologist, Dr. Matthew Dix, non-exec and psychologist and mindfulness specialist. And finally, me, I've come from a business and entrepreneurial background, and I have a unique insight into the industry as I've lived with diabetes for over 4 years. And our journey started by co-designing diabetes solutions with the UK's National Health Service. We built a community. We've now got an MVP, and we're moving into building some use cases with our academic partners and seeking pilot opportunities. As a new startup, we're honored to be considered as a finalist. By choosing NEEP, we believe this could be a mutually beneficial opportunity because you'll be supporting a solution that's been built with the empathy from people living with diabetes in mind. Together, we can break down some of the many barriers in access to mental health support for people living with diabetes. And with your support, we can hopefully reach our goal of spotting signs of diabetes distress sooner. So thanks for listening, and I'll be happy to take any questions.
Thank you, George. That was wonderful. Okay, at this time, George, can you stop sharing your screen?
Yep.
Thank you. And can I ask our judges to come back on camera? There you all are. Wonderful. All right, judges, fire away.
Do you have any early results and as well as sustainability in terms of how long people stay with the app once they start using it?
So the results we got at the moment is just through the community. So we built the community platform as kind of like a stress reduction, a diabetes distress solution, short-term solution. And from that, we've got a 60% retention rate. Sorry, that's return rate. So we can see that there's a problem here, and that users are wanting to solve that, and they're finding solutions. However, the app is very new, so we don't have any kind of usage stats on that. But moving into the next couple of months, we're working with our academic partners to find these sorts of that sort of information out. Sorry, Mimi.
Sorry, how are the users finding out about it? In other words, are you recruiting them? Is it out on the App Store?
No, so the community is just is kind of desktop based. It's kind of like a white label solution, while the app itself is on iOS test flight. So we're recruiting users for the testing of the app through the test flight kind of external link.
Hey, George, any since it's mental health and diabetes and members who are stressed, anything here for if you like a pre-screening for maybe somebody who's having a mental health crisis or an emergency that may need like immediate medical attention?
Yeah, so the way the support chat works is that we have, it's like a screening process. We use the diabetes distress scale is what we're kind of put into them to assess the distress levels. And depending on those levels, we offer either a mindfulness group, a one-to-one counseling session, or if it's kind of beyond us, we can point them to kind of crisis support there, where they can get some actual clinical help.
Okay, thanks. Because I'm always worried about somebody starting up who may be emergently suicidal or something to that like that.
Yeah, 100%. It's definitely something that's on our radar, and that's why we've got the kind of support from clinical psychologists to ensure that we're there to support them if needed.
Okay, thanks.
So follow up on that topic. What's your plan in terms of recruiting psychologists to work for your app to support patients?
So we have quite a good network in the UK of psychologists, but this is like a specialist area, because not only is it just psychology, is also diabetes specific. So we're working with a great psychologist at the moment, Sophie, who is has got a good network around the UK, and the way the app works is that there's a separate app, so they download that, and they kind of work and reply to messages and discuss on a kind of case by case. But yeah, it's like they get paid by the hour. And
so are these in-person consultation, or these just text-based conversations?
It's text-based, but it moves to virtual through video.
Okay, thanks.
Hey, George, you mentioned some kind of diabetes distress score. How do you go about actually, calculating that, and like what type of factors go into that?
So the diabetes distress scale 17 is like a clinical questionnaire that's specific to diabetes distress, and there's a score that comes out of that, and there's recommendations of how to treat it. If you like, I can get get our clinical psychologist to answer that question for you in more detail as a follow-up. But yeah, the diabetes distress scale is specific to this particular problem, so it's kind of there's pathways through that.
Got it. That makes sense. And in terms of like monetization of the solution, how are you looking at that?
So there's two there's a premium version. The premium is £10 per month, cheaper paid annually, and the content is what we're providing as the premium. So you get more content. There's still kind of like introductory mindfulness sessions, audio sessions, and articles, but the premium is the the more expensive, through you get kind of more premium articles, and then through the psychology consultations, that's kind of paid as and when as needed.
Fantastic. Seems like you wanted your colleague wanted to expound on the answer.
It just joined. Okay, yeah, cool.
Yeah, go ahead. Who's there? Right here. Go ahead.
Hello, sorry, it's a little late. I had a patient. I think I caught the end of the diabetes distress scale question. So yeah, working with that, it's sort of a recognized outcome measure around diabetes distress specifically, which is quite interesting because there's very few specific outcome measures. So that's a quite nice way of, I mean, George was talking earlier about sort of being quite sensitive. So capturing where people are in managing their diabetes in general, and sort of recognizing where people might be struggling a little bit, especially in particular areas, say around food and eating and diet. But also, so you kind of get that breadth, that sensitivity of how people are coping, but also you then are able to kind of get some of this sort of specificity about it, about where they might be struggling particularly, and also you're getting then a score which you can indicate sort of how distressed they are. So it's a nice way of capturing a lot of people and a lot of where people are, but also thinking about, okay, so what do we do next with this group of patients?
Fantastic. Thank you, everybody. Any more judges have any questions for Neep?
Hey, one last one here. I know that a lot of the diabetes distress comes from maybe not even the diabetes itself, but a lot of the external factors. And we talk a lot about social determinants of health. Any support on those type of things?
Sophie, do you want to go for that one?
Yeah. So no, I absolutely agree with that statement. It's often a bit of a tip of the iceberg. Often managing diabetes is kind of just another stress or something that maybe kind of tips people over into really struggling. If everything else is going wrong, managing your diabetes is just one more thing that's really tricky. So I think in terms of support, I guess kind of acknowledging that and validating that. I don't think that's always heard. Quite often, I think with health in general, physical health, people are kind of expected just to get on with it. But actually some validations through some of the articles that we've been working on together around really normalizing why people become overwhelmed with managing their diabetes, why people become distressed. I know the community are really fab as well and will also really help normalize that. And sometimes that is the first thing, is just saying, yeah, no, totally understand, totally normal to feel that way. I guess in terms of how much that is impacting on someone's management of their diabetes, would then you'd be thinking about what level to supply that support, whether that's just signposting to articles, whether that's signposting to community, whether it's actually moving on to maybe group support, one-to-one psychological therapy, will depend on kind of the severity. But yeah, it's and then kind of working together then to think a bit more, if it's very specific, about formulating, you know, what is contributing to these difficulties. Is it family, home, is it work, whatever, and kind of unpicking some of that as well. I hope does that kind of help answer?
Sure, thank you.
Fantastic. Thank you, Neep. Thank you to our judges. And we'll move on to the next. Appreciate it. Okay. Next up, we have Pac Health. Pac Health, are you here? There you are. We see you, Darren. Go ahead and share your screen. And the floor is yours. Thanks.
Can you guys see the screen?
Yeah, we can see it.
Okay. Thank you to Cigna and MATTER for the opportunity to share our story. My name is Dhiren Patel, and I'm the SVP of Sales and Medical here at Pac Health. A little bit about Pac Health. It was founded in 2013 and is headquartered in Birmingham, Alabama. We currently have over 200 employees and are quickly growing. We entered this space because we saw some obvious gaps in the patient engagement market. My background is from academic medicine, and having practiced for over a decade in a diabetes clinic, a lot of it I saw firsthand. And many of you are well aware of some of these shortfalls, and you see traditional call centers being utilized to close care gaps, disease management programs that focus on the top 1 to 3%, but not the rising risk, and an explosion of point solutions that treat one condition or don't focus on the whole person, including social determinants of health. As a result, Pac Health was born. So Pac Health is an evidence-based patient engagement platform that changes health behaviors to close gaps in care and improve outcomes. We currently do this in over 30 conditions exclusively for payers, global pharmaceutical companies, and self-insured employers. We do not have a direct-to-consumer offering. And I recognize the focus for today is diabetes, so I'll highlight some of our achievements and milestones in that specific area. We are the only digital health company to have American Diabetes Association recognition as a diabetes self-management support program. We also have a 3-year NCQA certification or accreditation in diabetes, as well as being the only virtual diabetes prevention program in our home state of Alabama. We engage patients in an omni-channel fashion without the use of an app. So we can meet patients where they're at, whether that be via text, email, or telephone. All of our program journeys are modularized and personalized so that every patient with diabetes has content and resources that are specific and personalized to them. We have the ability to do over the phone interpretation in over 197 different languages. And when it comes to going and solving for external factors, we go above and beyond when it comes to condition management and solving for social determinants of health. We have the ability to coordinate non-emergency medical transportation for a patient with diabetes to get to an eye exam, a foot exam, or even food delivery that I'll get into more specifics on the next slide. We also have the ability to remotely monitor a patient with integrations with over 450 connected devices and 99% of all diabetes devices, which include glucometers, continuous glucose monitors, insulin pumps, and insulin pens. Our platform allows us to address health disparities in many different ways, and some are featured here. We can care escalate to a telemedicine provider of choice, a designated case manager, or other emergency personnel that is specific to that program offering. As mentioned before, we can deliver condition-specific food to patients with type 2 diabetes, and you'll see an example of that on the next slide. Our offering to address food insecurity spans from being able to issue direct spend food cards from a payer to delivering food boxes, as well as medically tailored meals. Other examples that I mentioned include use of non-emergency medical transportation. So we have partnerships with Viora Health and others. And we also have the ability to address and track any additional gaps in referrals that are not in our program through integrations with Bertha and Unite Us. Here is an example case study from a Blues plan in which we are coaching and engaging patients with type 2 diabetes, along with delivering condition-specific food to address the food insecurity of those members. We have over 600 patients enrolled in this program. We have a 77% engagement rate at the end of 6 months with an 87% satisfaction rate. And as you can see there, that we have bi-directional communication happening with the patients. When you look at what is happening from an omni-channel perspective, we're averaging about 14 minutes on the phone on a weekly basis, 56 text messages that are going back and forth, 11 emails, and we're averaging about 104 touch points on average during that 6-month program. We've published all of our results. We have over 12 publications at different congresses, abstracts, and peer-reviewed journals. Our most recent one was featured in JMIR Diabetes, in which we were able to present our 12-week data cohort. So this was also featured at the ADA scientific sessions as a late breaker, in which we're able to show significant reduction in A1Cs for those that have an A1C greater than 9 and 10. And you'll notice here, those that have an A1C greater than 10, they're starting off at 11.3, and we're able to reduce that to by 4.2% to an A1C of 7.1. That was the 12-week data. We've also done longitudinal studies lasting a year long, which the second box was presented at the American Association of Clinical Endocrinology meeting a few years ago in Boston, in which we're able to show a 1% reduction in 3 months, and being able to have that sustained decrease over the course of a year. So again, a testament to the diabetes self-management, support and the skills we're teaching our patients. We're able to maintain that A1C decrease as well as the weight loss. And I'm happy to take any questions from the judges.
Thank you, Darren. Could you stop sharing your screen? Fantastic. Well done. Okay, at this time, could the judges come back on camera?
Hey,
Can
good
you
morning.
Oh, go ahead, Wendy.
No, go ahead, Angie.
I was going to say, can you talk about your solution in terms of health equity, addressing health equity?
Yeah, so it's a great question. Outside of some of the other pieces that we mentioned, currently 20% of our patient population that we engage are in rural areas. 30% of our patient population are African Americans. And so we've published this most recently at the Federally Qualified Health Centers conference for the National Association of Community Health Centers in engaging underserved patient populations.
Okay, one follow-up question. Can you tell us more about your health advocates, what their credentials are and what their experiences are with participants?
Absolutely. So all of our health coaches go through a series of training. So many of you probably recognize that there is a certification that exists out there called the National Board Certification for Health and Wellness Coaching. So we are actually a certified center to not only certify our coaches, but other coaches for health and wellness coaching. They also go through the CDC training for diabetes prevention, as well as the ADCES, formerly known as AADE, and they go through the certification process for the various levels that exist. So we have on staff everyone that is from board certified in advanced diabetes management to certified diabetes educators and to paraprofessional level 1 and 2.
Can I ask a follow-up question to that, please? And I'm sorry to jump in. When you talk about that, you have obviously many other conditions. Do you guarantee that the people with diabetes are assigned to those coaches who have the CDCES and are board certified?
Yes, we have dedicated and designated teams. We have teams set up in 4 areas: cardiometabolic, pulmonary, oncology, and autoimmune. And so the coaches are trained in those areas, and those are the conditions that they're engaged for.
Thank you.
You touched a fair amount of information what your company can offer. Can you provide some summary points? If I'm a diabetes patient, what area do you interact with me throughout the patient journey? I heard you have Uber food delivery, advisory, but some summary points throughout the journey. What are the key areas you impact patient?
Yeah, so we have our journeys that are as short as 12 weeks all the way to a year. Most of our payer contracts are a year in length. And so we have a curriculum that we've built out on the chassis of some of the diabetes self-management support and education programs that exist. And so that can vary from, healthy eating to exercise, social support, stress. And we're able to, all of our content is modularized. And so, for example, Wendy, if your concerns around stress and sleep, we can bring that module up, talk to you about that. And if Audrey has something around healthy eating, that's the information and that coaching that they get. So we have a journey, and that's that ADA certification that I had meant that they've reviewed. It's the same body that puts out the standards of medical care. They've reviewed that program, they've blessed it. And so that's the core program. And then on top of that, we have these additional features and integrations, whether it be through remote patient monitoring so that our coaches can see the glucose information. And so they're not just coaching and saying you need to, take more steps or you need to, do something. They're actually able to see your activity data. They're actually able to look at, glucose data if the patient so chooses to pair their device. And then we have others that we know there are a lot of external factors that contribute to diabetes management, such as food, and closing some of these care gaps, requires, transportation or going to a different providers. And so those are all additional features that sit on top of our core program.
Thanks.
Did you talk about milestones where you're going from here?
Yeah, absolutely. So I mentioned earlier, about 60 to 70% of our work happens with life science companies. We work with one of the largest diabetes manufacturers in the world. We also have several national large payer contracts, which is probably the next largest focus of ours. And so expanding to MA plans and continuing with life sciences is our kind of priorities going into 2022. We do have self-insured employers, but those are a lesser focus for us at this point.
In terms of how you match your patients with coaches, I touched on, if they're certified diabetes, do you do anything about, I guess, geography, personality, age, persona of the type of coach somebody might want?
Yeah, so when you enroll into our program, we have bios of all of our coaches. It's very similar to the consumer model. If you're, working with like a Birchbox or a Trunk Club, you get to see a little bit of background about that patient, who they are, their training. And so you have the ability to pick your coach. And, so if you want a female coach or male coach or someone with a specific background, you're able to pick your coach on program entry. Obviously, a lot of it is dependent on availability. If we only have certain folks available at Tuesday at 2 o'clock, then, there's some limitations there, but patients do have that option to pick their coach.
Great. Any other questions for Pac Health?
Can I ask one more quick question? So when you work with health plans, you particularly highlighted, can you share your arrangement with health plan? Is all the patient basis or only a selected patient who are impacted? And do you guarantee results? Yeah,
so we've worked with different payers in different ways. In some cases, we've done SDOH screenings for the payers, and then based on the findings of those are the ones that we've enrolled. So we also have an inbound call center, so we're able to do services like that. So we do SDOH screenings, and then those that test high, we'll enroll them into our program. We've also been given curated lists, and so patients with type 2 diabetes that they've found from an A1C elevation or through social work or HCP provider networks, whatever that might be, lab diagnosis codes, ICD-10 codes. And so we've worked in a variety of different ways where we're given typically some type of eligibility file, and then those are the ones that we've marketed to. And usually in year one, we don't do any performance guarantees, but we are in discussions with some at scale to take risk.
Thanks.
Awesome. Thank you, Pac Health. And thank you, judges. We have 12 startups total today. Pac Health was our 6th. That means we're halfway through. Hooray. And thank you guys for continuing to ask super insightful questions and clearly paying such close attention.
Well, thank you and hello. I'm Kimberly Cerrone, CEO of San Francisco-based Teatris. After my sons came home from military service with combat-related PTSD, we struggled to find them mental health care. As a neuroscientist, attorney, and entrepreneur and mother, I was inspired to do better. My vision was a platform that balanced the powers of human connections with the power of technology to create a scalable yet personalized mental health solution. We assembled a diverse leadership team of clinical, social learning, and software design experts and recruited over 60 collaborators who share our passion for solutions that truly unify physical and emotional health. We started by creating Teatris programs for traumatized veterans and migrant farm workers. We built programs for brain tumor patients and their often overlooked family caregivers. We are creating cardiac rehabilitation and diabetes programs with the American Heart Association. We created racial trauma and allyship programs for employee wellness. And we're working with the VA to address minority stress among hard to engage veterans. Everyone with an internet connection or mobile phone can use Teatros. When you log onto Teatros for the first time, you are greeted by an online learning expert who onboards you quickly and easily, who will always be with you throughout your Teatros experience. The most unique feature of our platform are peer groups, where participants work collaboratively in guided small groups. Expert-led videos and exercises teach scientifically proven cognitive behavioral therapy skills. Mindfulness meditations promote effective stress management and healthy diet, exercise, and sleep habits. Completing thought and mood logs and writing in an online journal promotes personal growth. And participants learn to recognize unhealthy behavioral responses and how to replace them with healthy behaviors. They learn how to cognitively reframe difficult solutions into manageable ones and how to have happier and healthier relationships. Experts explain the neurobiology of mental illness to destigmatize it. They promote the critical role that behavioral change and self-efficacy play in successful self-care. We work with our customers to include their leadership teams as peer role models who share their own stories and strategies to overcome emotional struggles. We benchmark our impact against the outcomes achieved by in-person psychotherapies. Teatros is consistently comparable. Participants with moderate to severe and severe levels of stress, anxiety, and depression typically improve to the mild or normal levels. We consistently achieve higher engagement than in-person psychotherapy, with over 75% of Teatros participants completing their programs and completing over 55% of their weekly exercises. We also have high re-engagement rates with over 70% of our participants re-enrolling after their first Teatros program. Clinical data are important, but sustained behavioral changes are what improves our participants' mental and physical health and their relationships at home and at work. We gather clinical interaction data throughout Teatros and apply artificial intelligence to detect, score, and continuously monitor behavioral attributes. Our platform gives participants tools they can use to sustain a healthy lifestyle. Next year, we'll launch our global partners platform for providers, payers, and digital solutions to give every care team a mental health partner and to democratize access to mental health for millions of people. Thank you.
Thank you, Kimberly. Appreciate that. Awesome. Moving on, could I ask the judges to come back on screen now? Audrey, I see you. Nico, Richard, fantastic. Wendy, go ahead.
Kimberly, can you talk about your solution in terms of addressing health equity?
Yeah, health equity is central to what we are doing. We're trying to reach those 120 plus million Americans that do not currently have any access to effective and formal mental health. So from the very beginning, we wanted to learn how to reach those people and serve them effectively. Our first implementations at UC Davis Medical Center were with migrant workers. Our programs with the VA are all focused on hard to serve veterans. We're working right now on a program to reach transgender transgender veterans. We understand the Davis application I mentioned. They needed Teatros in 6 languages, including Turkish and a Vietnamese language. So it is in our genetic DNA to focus on currently underserved populations.
And then in terms of your user base, do they skew to a certain age group, or what is maybe the average age of your users?
That depends on the specific applications. In one of our applications, for example, is a global high technology workforce. And we see a skew to millennials, people, in the 20s, 30s, early 40s. In our brain cancer application, that's an older population. We have people in their 80s there, and we've had to make design changes to accommodate maybe their eyesight or their agility with their fingers. Maybe they need, maybe they have cognitive delays. So we've gotten quite experienced at applying our platform to accommodate specific population needs.
Thank you.
Hey, Kimberly, it's Erin. Quick question for you just around age groups. I know diabetes when young children are diagnosed, maybe in their teens. Can you talk a little bit about if you have any mental health support for specific age groups?
Yes, we have we have licensed and are integrating a wonderful, expansive set of resources that was developed at the University of California, specifically targeting children and adolescents and young adults. And to date, our applications have been mostly with people over 18, but we're very targeted on the on children and adolescents.
In terms of measurements, I saw that you put up the GAD-7 and a few other, clinical measurements of anxiety or depression. Have you considered incorporating the diabetes distress scale and diabetes empowerment scale?
Actually, Mimi, thank you for that question. That slide represented an actual study and an actual customer that's being prepared for publication. But in fact, we work with the disease experts and expert psychotherapists to determine what we're trying to achieve clinically and how to measure it effectively in each application. So with the diabetes application, I would certainly think that traditional diabetes distress measures would be incorporated. But the thing you should think about is that if it exists online or it exists on a piece of paper, we can integrate it. And we'd use different measures for every applications.
Okay, thanks.
Hey, Kimberly, how does, you just mentioned kind of that diabetes program or module, how does that program, I guess, like tailor to the unique needs of like the diabetes population?
It will probably be it's not a program, it's a suite of programs. I mean, when 11% of the United States is diabetic, whether they recognize it or not, what someone who's employed, relatively healthy, been recently diagnosed, is highly motivated to take care of themselves to the best of their ability, they need one set of tools and interventions. Someone that maybe not engaged in their health, not really focused on healthcare, has been chronically underserved, neglected their health. Maybe they speak a different language. Maybe they're poor, less well educated, more rural, lacking in resources. We design a program that's optimized for them. So we will have many programs for diabetes and pre-diabetes and diabetes prevention.
Got it. That makes sense. In terms of like, how does that personalization happen? Is it like, people putting into their data into an app, or is it through a conversation? Like, how does this, I guess, like unique, program get established?
Seth, do you want to answer that question? How we optimize programs for both given specific population and individual users?
Yeah, absolutely. So we built a very flexible platform so that depending on the use case, we can have it so that people are able to come in individually on the Teatros platform and get comfortable with it and see maybe shorter, simpler exercises to support them on their journey back to health. And we sort of invite them into ultimately, what we want them to do is get into these peer groups and go through programming together so that they can build these long-term supportive relationships. And the way that we make it work is a balance of synchronous and asynchronous participation. So regardless of your schedule, you're able to come in and work at your own pace. But by the end of each week, the coaches are encouraging people to be, wrapping up their work, sharing it with their peers, and connecting and bonding over it. And that also ensures why we have such a high completion rate, this group work. And so it really is striking that balance of meeting people where they are and where their schedules are and inviting them in regardless of how busy they are, but ultimately pushing them towards a conclusion, which is to join these groups and wrap up these programs on time.
Awesome. Thank you, Kimberly. Thank you, Seth. Thank you, Teatros. And to all of our judges, we appreciate it. I know that this call is getting long, but we still have 5 more startups. And I promise I will let you get your steps in after Viora and take another break. So next up, we have Viora Health. Deb, are you there? Judges, I'll ask you to go off camera now. And Deb, I'll ask you to come on camera and share your screen.
Hi, can you hear me?
I can hear you. Yes, great. Fantastic. There you are.
Right, I was on last time, but it didn't work.
Okay, go ahead.
Okay, so you can see my screen, right?
Yep, we can see your screen.
Great. Hi, I'm Debolina Dutta. I'm a Wharton MBA with 20 years of operator experience. I'm a 2-time founder and the CEO of Viora Health. I'm going to start with the story of Sheila. She is diabetic, works long hours, cares for her elderly mother and 3 kids, lives in a food desert, and faces low health literacy. Her doctor prescribes treatment and asks her to exercise and eat healthy. But Sheila shows up at the ER because she did not change her diet and she stopped taking her medicine as a result of SDOH and behavioral barriers. She faced poor experience, poor outcomes, and this resulted in higher costs. In fact, 70% of people like Sheila drop off evidence-based protocols. And on the other hand, 80% of outcomes are driven by SDOH and health behaviors. And this low engagement and drop-off is costing us billions of dollars in avoidable ER visits, missed doctor's appointments, absenteeism, repeated patient failure, and disease progression. Introducing Viora Health. We empower people to thrive in their own communities by engaging them to stick with their healthcare protocols at home and by reducing social and behavioral barriers that stand in the way. So Viora is essentially a personalized engagement solution, which is made of software and service. We help members with high social needs and moderate to high utilizers of hospital services. We've created technology to assess individual needs using 40 data points to first triage people, identify and prioritize barriers, and create a personalized plan, which is made of curated content, peer group support, and community resources with 5 to 7 automated touch points per week, goal setting and tracking data. Further, members are supported by a Viora case facilitator, who's typically a community health worker who is well-trained and culturally competent, and powered by automated decision support to provide trust-based advocacy. Finally, we report performance tracking and additional support to providers and payers to better align them and close the feedback loop. The current remote patient monitoring services fail to acknowledge health literacy and technology gaps that exist among underserved. Our solution is low friction with sophisticated back-end technology, but in the front end, it's as basic as receiving text messages with no download or behavior change needed. Our content is provided at a 6th to 8th grade reading level. And it's important to note that while pushing patients into funnels that they're not ready for is what's happening right now, we focus on gaining buy-in and keeping buy-in. And we have the results to show for it. While 70% of minorities dropped off diabetes prevention programs, our retention rate was 88%, with reduction in weight and A1C and an improvement in patient activation, sleep, and stress. Our target population was underserved minorities, economically disadvantaged, pre-diabetics and diabetics who faced social determinants of health barriers, such as low health literacy, social isolation, food insecurity, and access to transportation. And we have great testimonials from participants. Now let's revisit Sheila. Instead, if she was referred to our app, we would have closed food insecurity gaps by sharing a food delivery program, which we did in her case because she did not want to pick up in person. Further, we moved her from consuming 2 liters of soda at a time to substituting with a sugarless fizzy drink. Through education and tips over the course of a year. As a result, we reduced barriers, educated and improved Sheila's confidence to take care of her own health. And as a result, improved her experience and resulted in better outcomes. Our traction has been phenomenal. We've developed product based on extensive customer discovery with 250 stakeholder interviews of community health workers, doctors, plan managers, and further iterated it by observing patients at the ground level. We've evaluated 3 data sets to develop our predictive machine learning algorithms and built and tested our product and submitted data to the CDC, which exceeded performance metrics to be fully recognized as a provider for delaying and preventing type 2 diabetes. In terms of backers, we have National Science Foundation, National Institute of Health, J&J Impact Ventures, Village Capital, and we are looking ahead to partnering with community-based organizations over the next year and scaling that to contracts with health plans and health systems that we're in currently conversations with. Our value is to really reduce the workload, reduce costs, and collect social determinants of health as well as patient-reported outcomes to improve access to care and improve patient experience. I'll take questions.
Awesome. Thank you, Deb. You could stop sharing your screen. Perfect. Okay, and our judges, I'll ask you to come back on. There you are. There's Wendy and Audrey. Fantastic. Judges, handing it to you.
Hi, Deb. You spoke about a 88% retention rate. At what time period is that?
1 year.
1 year. Okay, thanks.
Hey, Deb, you mentioned, you kind of include or incorporate community resources. What can we kind of imagine under that? What does that all encompass?
Right. So the few resources that I've shared is food banks and food delivery in the patient's own community based on their need as well as based on their preference, as I cited in the example. Others are advocacy and support and closing of knowledge gaps by sharing covered benefits within their own community, such as safety network of providers and social services. We use databases such as 211 as well as Bertha in order to make those recommendations, but it's powered by technology in order to customize and personalize that option based on that individual's need.
I have a question. You talked a lot about cultural competency and all the different social determinants of health. Do you guys are you planning to offer a multilingual and also include special services for people with disability to make it more inclusive?
Yes, so we actually, in our assessment, the ADLs are one data point that we collect. And so we have the adjustments I would speak to that we've done is, for example, shared resources such as physical therapy and customized exercise tips in order to cater to that particular disability. Another could be comorbid conditions, for example, COPD present in addition to diabetes. So adjustments made to exercise recommendations and resources within the patient's community based on that need. And sorry, to the language. We are offering the 8th grade proficiency level in English right now, and we are looking to expand to Spanish and other languages in the future.
Just one more question. You talked about the barriers in using services like 211 and Bertha, and you said about being able to provide reporting. So do you guys use a closed loop where you confirm that the individual was able to obtain the resources in the community?
Yes, in fact, that's what I mean by closing the feedback.
Thank you.
Deb, I had a question about scalability here, because I know that sometimes, accessing all these community resources can be a lot of work. How many markets are you in, and do you see that kind of a rapid scalability being an issue?
Right. So I think the way we are looking at it is, again, right now we're benchmarked against, I think, industry standards in terms of facilitator to patient ratios, which vary. It's a range anywhere from 100 to 250, but we are using the funding that we received from the NIH, particularly the Institute of Minority Health and Health Disparities, is specifically to create efficiencies in that regard by using AI to, for example, collect information seamlessly. And so that'll allow more scalability as we expand to other markets as well as other disease states.
Thanks.
Great. Any other questions for Viora Health?
Hello? Hello?
Yes.
Oh, yes.
Sorry, if someone's asking a question, it's a little bit hard to hear you.
Can you repeat the question?
I think it was just somebody's audio on. Okay, fantastic. What kind of diabetes challenge would we be if we did not give you time to get a snack and up your blood sugar? So it is time for a break. Thank you guys all for, again, the fantastic presentation, fantastic questions. Next up is Upfront Health.
Thanks for having us. Really excited to be here, excited to hear about all the new innovations. Love to talk about innovation. There's been a lot that's been going on, as we all know, in the industry for some time. And I don't know why my slides are not changing. Speaking of technical difficulties. Wow, that's not an auspicious start.
No worries, Bob. Oh,
Okay,
there-
we got it? We're good? Okay, so I had a front row seat as the CEO of GlideTech to see all of the great innovations in the industry over the last many years. Advances with connected BG meters, CGMs, pens on the pump front, all the way to AID. Certainly in terms of analytics, behavioral, we've all seen that. We're hearing about more innovations today. It's great. And then on the therapeutics front, we've seen more drugs coming out all the time, and the ADA has told us exactly how to use them, for whom to use them, when to use them. So we would certainly expect to be seeing a lot better results than we are. And just in the aggregate, the outcomes aren't there. We would diagnose this largely as a failure to engage, or more specifically, to be engaged. Patients seem to be somewhat lost and members in the system throughout, and they need an awful lot of guidance and care and a lot of intervention. So that's in part why I joined Upfront, leaving GlideTech. It's all about really care navigation for us. So navigating patients to the care they need is what we're all about as an organization. That's our true north. So this is true across every kind of patient, population, zip code, any condition management initiative, and especially with diabetes. So Upfront is focused on solving the problem of care navigation for every patient efficiently and effectively. And we do this in a proactive and personalized way. It starts with our next-gen communication and engagement platform. We call it Care Traffic Control. We reach members through IVR, text or email, primarily text increasingly, providing the kind of connective tissue that actually makes a positive difference. So really helps guide people and educate them to where they need to go. At the core of it, simplistically, is something we call a microsite. So that is just a personalized and secure landing page. It's content rich like an app or a portal. Unlike an app or a portal, it does not require a download or a login. So it's just one click to get to the information they need. It may come from a trusted provider with a message and education about what it is that they need to get done. And with every outreach and interaction, that bond between the care manager and the patient is strengthened. The success of this unique success is reflected in engagement rates that are unprecedented in the industry, and conversions ultimately, and with world-class health systems that we have on our roster today. So to illustrate this a little bit better, let's look at a couple of patients. So we have Angela and James. Both are with, both have type 2 diabetes. Angela's been enrolled in the MA plan for some time, while James is new in the commercial plan. We've learned a lot about Angela. So this is data driven. We've ingested a lot of data. We know that she prefers to be contacted by SMS and in the morning, primarily before she goes to work. And we know what is next in terms of her care path. In this instance, she may need a booster or a vaccine. James, on the other hand, we're welcoming into the system. We don't know a lot about him. He hasn't had an AWV in 2.5 years. So we're trying to get him enrolled and may not even have a PCP, and we're going to help him do that as well. Along the way, we're going to send reminders about visits. We're going to talk about their preparation with them. So as we start to bring Angela through and things are starting to happen with her, she completes her vax, we're going to talk about what's next. So it could be an A1C and other diagnostic like a kidney exam or something of that nature. With James, it's been a little bit harder to enroll him. Not everything works the first time around, so we try to reschedule. We have a one-click way to reschedule into the system. We go further, talk about additional things that may be done. So with James, we're not getting him in the system. We may employ a survey through IVR to find out exactly what would activate James. Finally, just bringing this around to some of the 85 use cases we have. From a medication adherence standpoint, we could get Angela involved in refilling her metformin, where James has indicated through the survey that he's interested in RPM. And then we're going to start to ask him if he has a CGM. So getting him into programs. So we have 85 different programs. It's all about getting them to the care that they need. From a health equity standpoint, some great evidence here with regard to what came together in Hartford, where a program designed, really careful outreach, personalized engagement dovetailed to deliver a significant increase in engagement across a large population, and in specific in hardship zip code, something we're really, really proud of. So we help drive a better vaccination rate than other states, but in particular, really proud of what we did in the hardship zones. Here's a case study as it relates to high-risk diabetes group population health initiative on the part of a big Midwest academic medical center. Much greater engagement, all back to that personalization at the end of the day, and many other examples of our ability to get into those hardship zip codes and those folks that are outside the system looking in and engage them through a very personalized approach. So in the end, it's about building trust between their provider and the payer, help them to navigate this really insidious disease, create awareness, demonstrate to them that we care, demonstrate that we know what's best for them and on the horizon for them, and help them achieve the best possible outcomes in terms of asset utilization for you, all of those things that you made heavy investments in, and in terms of fostering that essential relationship with folks in the end.
Fantastic.
Okay.
Are you done, Bob?
Yeah, let me see if I can, yeah, done.
Fantastic. Great.
You okay? Good.
Yeah, we can see you.
All right.
Sharing
Hi there. Good. Okay.
Awesome. So Bob, if you could stop sharing your screen, and the judges, you could come on screen.
Good.
There it is. So I see Richard, Nico, Wendy. Mimi, are you coming? There's the me. Okay, fantastic. Judges, questions for Bob?
Yeah, can you talk a little bit about the metrics for your success so far in terms of clinical outcomes?
In terms of the clinical outcomes, largely we have data around visit adherence, making sure that people are seeing their visits, getting the care that they need in general. Our clients have largely not been able to provide for us the end outcomes. At this point, there's a number of case studies that are developing. We're really, really focused on that. The organization is all about outcomes. You'll see case studies come out over the next 3 months. The engagement and then the conversion to appointments would certainly indicate that we're seeing better preventative care and better outcomes, but we really need our clients to bring a lot of that data forward. We ingest a lot of it, but we're putting together studies together that we will publish soon enough.
So would you describe yourself as a gaps in care and engagement organization, or diabetes care?
Absolutely. And more than the 5-minute presentation, we're really good at care gaps, but we're doing a lot specific to chronic diseases. And so we are, as I said, kind of that connective tissue that's guiding people to the care they need. We're kind of the Sherpa in bringing them through the system, if you will, proactively. So just ingesting data from the EMR or from whatever host system that may exist, and then determining what's next. So don't think of us in terms of campaigns. So, hey, we're just going to go and run a Mambo campaign. This is a sustained digital relationship that is all about core care management and care coordination in the end. So we're seeing these much higher engagement rates given the approach that we've taken. And those engagement rates are turning into activation or conversions, as we call them. So the appointments or the diagnostics are happening. What's the end outcome, with various populations is kind of what's next for us. We've been out there for 6 years now in a lot of big healthcare systems and with some payers, and again, working with them to publish those end outcomes. Other questions?
Hey, Bob. So when you basically, let's say, reach out to a patient, do you reach out on behalf of, let's say, the health plan, or do you go, identify as like Upfront Healthcare?
So branded to whomever the client may be. So could be a medical group, could be a large health system or AMC or the payer. We do all of it. So every communication is branded from the client. And quite personalized. So if it's their physician, they're getting a note from their physician. So it's somebody that's trusted. And then the content it continues to be curated over time. So as we're ingesting more and more data, we're applying machine learning approaches to our algorithms that tell us how how we talk to that person individually. So these aren't generalized campaigns by any means. So if we're working with an individual client, they might say, okay, we have a lot of dormancy on the mammo front or with colonoscopy. We'd like you to do more. With A1C, we may do a generalized campaign, but it becomes very specific to the individual. And it could be subgroups within that provider organization or payer organization. It's a lot of the content that we provide from a health comms standpoint.
Hey, Bob, are you
Hi.
able to get much traction for those I don't call them contact hesitant patients, you know, the ones that need the assistance and you keep trying outreach and you get nothing back?
Yeah, so that's where I think the big distinction is over what's been happening historically. So it is personalized. Whatever data we can get on them, we're learning, and we're trying to take an approach where indeed it's branded or from a trusted source, and it's very pointed towards their situation. So our success from a health equity standpoint is very much about the personalization with any data we can get. And over time, it becomes much more personal to them. But this is the thing I think we're most proud of. If you really dive into our case studies, at the end of the day, we're just getting a much different engagement rate than what's been historically seen from, you know, just say a traditional texting vendor. And it's so much about talking to them in a way that is specific to what their interests or needs are, rather than just taking a generalized approach. So the data are phenomenal with respect to getting the stubborn or apprehensive, or those that are feeling that they're kind of outside of the system.
Great, thanks.
Bob, I have a question. In addition to provide engagement with the patient, do you also by any chance provide any navigation in terms of connecting patient to high performance providers or any other provider space? How do you provide guidance to patient in addition to just communicating with them?
Yeah, so great question. So I referenced on one of the slides, we'll use ClearStep or some other routing applications to be able to get folks to the more appropriate venue of care or group within these big health systems that we deal with. We have lots of very large health systems with various medical groups, specialists. So in context of diabetes, if we thought type 2 was with a PCP and it was time to get to an endocrinologist because it's the appropriate moment to move to insulin, then we're going to refer them over to the appropriate source. And that's a lot of how we're managing, you know, just reams and reams of data that tell us where the most appropriate venue and care providers may be, and driven largely by what our clients will tell us. But, you know, at the end of the day, it begins to be something that becomes automated according to what we've been told.
Fantastic. Awesome. Thank you, Bob. Thank you, Upfront Healthcare. Thank you, judges, for these.
Thank you all.
Time is flying by because we're having so much fun. Next up is Perception Health.
Thank you so much. Really appreciate everyone's time today and this conversation. I am Todd Featherling, the founder and chief data scientist of Perception Health. When we started this challenge, question came up about why diabetes. My cousin grew up with diabetes. This takes us back to a Thanksgiving dinner when we were talking about how she has had a lifetime of managing her lifestyle and the care team members around her. So I decided to use our data and my time to really do some research on diabetes, in particular, why some people progress faster towards CKD and ESRD while others do not. Perception Health, we're a disease prediction company enabling the early detection of the disease and changing interventions to help improve the outcomes of the patients. How we do what we do is our solution is a novel approach to diabetes care. And we do this by understanding how the delivery network is impacting the progression of pre-diabetes to diabetic type 2, to chronic kidney disease and end-stage renal disease. What we do is design processes and workflows to minimize that progression of diabetes and then optimize the resource utilization. You can use this for creating and optimizing delivery networks, patient self-navigation through plan guidance, care navigators to help assist and schedule those members for care, and also utilization by ACOs for optimizing the medical neighborhoods that they care for. Our model is one of identify, engage, and optimize. In the identification, we're doing disease predictions across the population for those people who are at risk for type 2 diabetes. Then we engage with the members and patients in a HIPAA compliant way where we're providing the patient name and information back to the plan and providers that we work with. Ultimately, we want to optimize the care pathway for those patients who are receiving that care. And that's where we're going to focus our time today. We do that through an algorithm that we created called VOCAL: volumes, outcomes, charges, access, and loyalty. We take and measure those parameters across all of the providers in the network that we're studying. In today's example, this is actually real world information. Dr. So in Chicago has 400 patients under care for type 2 diabetes. We studied the practice. They have about 1.6 million annual spend, just the one physician. And what our analysis tells us is that we could do cost savings of about $4,000 per year per patient by optimizing the care team and really working to identify earlier and help prevent the progression of diabetes type 2. If we could get 10% lift from the engagement with this one provider, we would anticipate cost savings of about $165,000 for that one physician per year. We also believe and have shown that the patient experience really improves a lot through decreased number of visits, but ones that are more meaningful in nature. Give you a quick example of what this looks like from a care pathway. This is what we call a slope of care. And as you see, the patient is progressing from pre-diabetes to ultimately a diabetes type 2 diagnosis. At the top of the curve there is where it's not optimized. In the case of Dr. So's practice, we looked at his practice and the care team around him, and we were able to switch out a few of the providers who are providing care today for his patients, both downstream and upstream. And as a result, we can show these kinds of significant cost savings and improvement in care to the patient by really extending that time that a patient is in pre-diabetic state as opposed to converting over to a diagnosed diabetic type 2 patient. What we're proposing is to implement a neighborhood-based diabetic care model. This would be designing a high-performing network in those most vulnerable areas of Chicago or other markets that might be served by Cigna. We would create the optimized care team using our VOCAL algorithm, and then geographically place those provider networks so that access would improve. In addition, we would have neighborhood-based care navigators to work with those members and patients to help them navigate to the right care at the right time at the right price. Thank you so much for your time today, and look forward to any questions that you have.
Thank you, Todd. Amazing presentation. If you stop sharing your screen, there you go. All right, at this time, I'll ask our judges to come back on. Judges, deep breath, you're doing great. 2 more left, and we really appreciate this. And your questions have been amazing, so fire away.
In terms of finding the optimal providers, how do you work with getting that data in terms of, I guess, directory information, claims information, like what's defining that path to optimal? You know, here we do have in our directory high performing providers that we direct people to. how do you work in conjunction with an existing classification? For instance, an insurer may have that versus your data that perhaps may be different.
Yeah, that's one of our core strengths. We manage about 29 billion medical claims today on 280 million unique lives across the United States. And we have 5 years worth of history on those lives. And so we can, day one, look into Chicago like we did with Dr. So's practice and pull out all of the patients who are pre-diabetic and manage their, or review first what their care pathway is today before it's optimized, and then look to see the other care providers or trees that are nearby. And we're able to build those care teams out of that data that we already manage. And so that's an all payer database, both commercial as well as Medicare.
Okay. What's in it for the customer? I mean, you're telling them that you're optimizing their care. A lot of these people might have been going to these providers for years and years and trust their treating physician because they've treated their family. How do you approach telling somebody that, you know, it might be better off if you've gone somewhere else? And how do you deal with that physician who might feel differently?
That's a really great question, Mimi, and you hit the spot. You hit the nail on the head, right? So the care optimization, we start with the provider themselves, in this case, Dr. So. And what we're doing is working with Dr. So to look at the other providers who are touching Dr. So's patients and re-engineering the care that Dr. So is then going to direct those patients to. So the patient trusted relationship is with Dr. So, and then Dr. So with additional information, insights into how his patients are getting care would then change the care pattern for those patients.
So following that concept, when you go to market, do you go directly to providers or you go to health plans?
Today, we go through self-insured employers, health plans, and occasionally providers. Some of our disease states like lung cancer are being used by providers today. And then others where there's a self-insured employer involved or a plan involved, we're much broader and looking at a lot more of these types of chronic diseases.
A question. So you're not really moving patients from one provider to the next. You're kind of adding an additional layer or network on there. Is that right?
Yes. Well, in some cases, we would be restricting where patients go, like for lab work, identification of imaging studies. And so we would be recommending a different provider that those patients would go to. The care navigator also comes into play by helping make sure that the access points that we've opened up are available to that patient and they can get there with adequate transportation and other components that might be important, especially in these vulnerable neighborhoods that we've studied in this particular case. There are other cases where, yes, we would be adding an additional network provider where we have access issues and or we find a much higher quality nephrologist who also has been proven to stop the progression of the disease. That's really the key, is understanding which of the providers in the network are working to stop the progression.
Okay. And are most of your patients have providers already, or are a lot of them like underserved and don't really have, say, a PCP or specialist that they need?
I would say it's probably about 50-50. So a lot of them will have a provider, but where we get engaged is when they have a newly diagnosed disease. So I've just been diagnosed with lung cancer. Where do I go? I need a knee joint replaced. Where do I go? I have type 2 diabetes. What will help me figure out where to go next? The other times that we get called in are where somebody's had a bad outcome and they're looking for a new provider, a second opinion, if you would, to be able to engage with somebody brand new.
Okay, thanks. I think I understand the space a lot more now.
Thank you, Richard.
Is Glucose Path.
So our solution is Glucose Path. It's clinical decision software that helps lower costs and improve outcomes for patients with type 2 diabetes. We think it has value in helping providers deal with the complexity around choosing a treatment regimen. If you're a provider, you know that the number of medications coming to market is growing every year. And we think that for a typical patient, there's anywhere from tens of thousands to a few million viable treatment options to consider. Providers are smart people, but no one's doing that kind of analysis in their head. And so that means there's a risk that the best options aren't being used. We also think it's critical to have patients tell us explicitly about important things that are often barriers to adherence, such as out-of-pocket costs. And that's asking a lot of providers to deal with in a 10 to 20-minute office visit. Our software relieves that burden by evaluating every possible combination of medicines that could be prescribed, along with the patient's medical history and preferences. So we're all familiar with the treatment algorithms like the ones published by the ADA and ACE. Our software's decisions look really familiar to anyone who's seen these flowcharts. In fact, we reverse engineered the basic building blocks of both algorithms by asking fundamental questions like, why is metformin recommended first? But our software extends these algorithms by using patient input, like cost and injection preferences, as key drivers for decisions. And those things aren't part of the ACE or ADA algorithms. We think the software offers material benefit to payers, providers, and patients. For payers, the first thing to note is that the software prefers medicines that are on the patient's formulary. We know that payers spend a lot of time on cost-benefit analyses for formularies, and that analysis only works if the formularies are actually used. A second benefit to payers is that the software's decisions are based entirely on standardized data and treatment rules from the FDA and peer-reviewed studies. So a pharma rep can't influence the software by buying at lunch, and television ads have no effect on the software's decisions. Everything's based on clinical evidence. One question we've got from other payers is this, for example, how do we reallocate the X dollars per year we are already spending on diabetes to improve the overall population A1C? And for one system, the thing we found was a lot of branded DPP-4 use, especially in patients with A1C levels under 7, where a generic drug probably would have done just as well. So that system was paying around $300 per month for the DPP-4s versus a few dollars for generics. For GLP-1s and SGLT2s, we're able to model the likelihood of a specific patient receiving cardiovascular or renal benefits from those meds based on their comorbidities and other factors. For providers, especially primary care physicians, a big benefit of using the software is that its A1C results are comparable to that of an endocrinologist. Many providers have performance bonuses based on their population A1C, and the software helps with that. A second benefit for providers is that the software helps reduce patient callbacks. Callbacks are really unpleasant for providers. They often happen when a patient is at point of purchase, and that's not a great way to practice medicine. And providers typically also don't get paid for those calls. One interesting thing the providers have told us is that the software's explanation for a particular regimen is a great teaching tool. So some providers say, for example, that they're prescribing more pioglitazone because the software reminded them that PO has a stroke benefit for patients with certain comorbidities, and it's a cheap generic medicine. A big benefit to patients is that the software facilitates shared decision-making. We ask specific questions about monthly medication budgets because we know that patients won't take medicines they can't afford. And we also ask about lifestyle factors such as in-home and out-of-home work schedules, because those things can also affect adherence. Here's a screen cap of our software. It's one page. Patient data is on the left, and the software's recommendations and explanations are on the right. The software runs on desktops, tablets, and phones, and no special software is required. It's a standard web page. Here's our roadmap and timeline. We started out in 2016 by taking a prototype of the software to the annual ACE conference. The software won first place in that year's poster competition. Based on that, we completed FDA review in 2017 and started a successful one-year clinical trial. I want to highlight our 2-year project we just finished last year with Kentucky Medicaid, where we were able to change the treatment regimens for around 150 adult patients with type 2 diabetes. Patients who followed all or part of our suggestions showed a 2.1 point drop in A1C, and most of that was at the 90-day mark, and that reduction was largely sustained through 1 full year. In addition to that 2.1 point A1C reduction, our project also showed a $770 per patient per year decrease in unplanned diabetes-related Medicaid costs. Our focus for next year is to continue to improve workflow and UI around the app And we're also super interested in seeing how payers and systems can use the software to reduce costs and improve outcomes. Because the software is a well-defined decision-making tool, it can be used by a wide variety of healthcare professionals, such as pharmacists, and using telemedicine. That expands access to the kind of specialized care normally provided by endocrinologists, especially in rural areas and for those who have difficulty traveling. And we know for some traditionally underserved populations, there's often an awkward socioeconomic dynamic that can prevent some information, such as affordability, from ever being discussed. But by having those explicit prompts in our software, along with things like weight change and side effects, we think patients will more easily be able to voice their concerns and be heard. In turn, that'll help patients take ownership of their care and be more likely to adhere to their medication regimens. And we know more research is needed around how to ask these questions. It's one of the things we've specifically asked the NIDDK, and would love to be part of further research on that. We can take questions now.
Awesome. Thank you, Len and Glucose Path. Len, you can stop sharing your screen.
There you go.
Thank you. Judges, welcome back. There you are. Judges, take it away.
Can you tell me a little bit about if you have any actual learning about lower socioeconomic groups and how this might have helped them, or how they may have resisted or felt awkward about it?
So we've done a couple of things. We noted in our first clinical trial that the average amount of money that a patient says that they could afford for their medication was $37 a month. And we, the way that we determined that was by looking at the first answer to the question and then the end answer to the question. So if providers ran the software more than once, what was the number that they started at and what was the number that they ended at? And we, my partner's practice is in rural Kentucky. So that was rural whites. We then went to the NIDDK because they had presented at ADA in 2019 around that exact how that exact question is difficult to answer for Black Americans. And so for the NIDDK, we traveled to Washington, we sat down, we presented to them. And in the end, they told us, we don't really know how to ask that question better, but more research is needed. And that's where we're at now.
Thanks.
Oh, go ahead.
Sorry, go ahead, Audrey. No, I have a lot of questions. Go ahead, Audrey.
So it seems like your solution and your software enables providers to give the best possible care. Is there a component of this for the patient themselves, or they just benefit through the provider?
When we went through FDA review, they were pretty insistent that this be a provider-facing tool, not a patient-facing tool.
Okay.
So that's where we're at right now. Yeah.
Great. So the provider will ask the questions and then input the data.
Exactly. And there are a couple of ways you could do that. One is just to save time with the encounter, you can ask the questions up front and have like an MA enter the data.
Yeah.
You can do it ahead of time, things like that. Yeah.
Okay, great. So I guess my big question here is, so I'm assuming you put in comorbidities and things, but do you have data and feedback around direct patient costs? So not total cost of the drugs, but direct patient costs versus like member fills and adherence?
Give me an example of direct patient costs, just so I know.
So you're saying my average member copays went down by $10 a month, can lead to adherence increases of, and whether using PDR or sorry, PDC or something else.
For our Kentucky Medicaid trial, we were not able to get system costs for the medicine, so we weren't able to directly compare those. We did some work earlier this year with the VA. We were able to get those system costs because they're publicly available, but we haven't yet linked those two together. And that's sort of the big question that we would have for Cigna. How much do we balance off the short-term costs of prescription meds with the long-term benefits, especially around things like SGLT2s and GLP-1s, where we know that there's a cardiovascular or renal benefit, but we need to know sort of what numbers Cigna or other organizations would place on that so that we can do the appropriate calculations. Does that make sense?
Yeah, yeah, totally. And I guess my final question here.
Sorry, one more thing. We actually have that built into the model. So if you look at different studies, we have specific values for those. Obviously, they're tunable, but we started somewhere.
Yeah. Okay, great. So my follow-up here is any feedback for the provider, say for the member adherence.
I'm sorry. Can you restate that?
So the tool helps calculate for the provider what drugs should probably prescribe, right?
Mm-hmm.
But anything, so when the patient comes back,
mm-hmm.
Anything to show the provider if they open up the tool again, that the member's been here, they've been filling their meds, or is this more of a one-time get the patient started and then come back when you need to come back?
That's a great question. We haven't yet linked the software to med reconciliation. And when we finished our Epic integration, we expect to implement that with our first system next year, and that'll be part of our solution as well, to make sure that people are actually taking the medications that they've been prescribed. And that's actually a huge point. Like one of the questions that we ask in our software is what medication the patient's already taking. And in our training during our clinical trial, we had to emphasize that that's medication they're taking, not medication they're prescribed, right? Because those are two different things. Yeah. So med reconciliation is still a key point. We think that'll come from Epic, but we haven't yet seen it in practice.
Okay, thanks.
Always really, really insightful questions. Anybody else have anything for Glucose Path?
So how do you compete with discount drug providers such as GoodRx? Rather than you offer patient within their formulary to go with a cheaper price, what if patient goes, I want to get a GoodRx, similarly achieve my cost saving goals?
We actually incorporate GoodRx prices in as part of a formulary that's based on cash prices, and so that you can do the comparison. The other thing we're able to, let me stop there. Does that make sense?
So as a patient, do I get to choose whether I go with the cash formulary or the formulary that's given to me during the workflow of the provider when they prescribe the drug?
So we have the ability to do both. So you can compare apples to apples on both. So for example, if you wanted to see what the cost was on your specific formulary, paying whatever copay you pay, that's one thing. You can also run it through and say, if you paid cash or if you used coupons, we have the ability to incorporate manufacturer coupons into the software as well. You can do that. A third thing you can do is if you have access to a free clinic. Let's say you're getting your insulin as part of a subsidized plan. There's a particular input field in the software that says, I'm getting this drug from this particular free clinic as well. So that's how the cost is computed. And this was a really interesting question, because when we worked with the VA, when we did our VA work earlier this year, one of the things we pointed out to the VA was, although they have excellent pricing for medications, something like 35% of veterans are eligible for Medicaid, and under Medicaid, the veterans would often pay less than they would even pay for the VA. And so our recommendation for the VA was that if you want to bring more people into the system, if you want to provide more care for veterans, the way to do that is to be able to give them both prices and see what would work out cheaper for them.
Fantastic. Thank you, Len. Thank you, Glucose Path. Sorry, Richard, did you have one last small thing?
Yeah, can I just ask one follow-up to Wendy's question? Do you have in there a model for patients who have like a high deductible plan? Because I've seen some where it's like, oh, well, the cash pay is cheaper now, but can you model it out, say, for the 12 months?
We do. And we have the ability to do Medicare as well, including the calculations around the donut hole and then catastrophic coverage. I actually want to bring my partner, Brad Eilerman, in, who's an endocrinologist, who can explain sort of the intricacies around this in 30 seconds or less.
Yeah, it's one of the most challenging things that we end up doing on a day-to-day basis is figuring out the prediction that comes with regard to coverage gap and deductible. And you get some surprising findings. What we find is in patients that are very far from goal, at least with regard to yearly calculation, it's better to double down on a highly effective regimen than to increment up, which ends up costing the patient more in the long run. So it's an excellent point that you bring across, that there's some intricacies there, and the software can handle that too.
Yeah. You end up with some not obvious solutions to begin with, but then when you look at the math, it all makes sense. So it's
Okay, that brings us at time for a glucose pad.
Thank you.
Guys so much. Appreciate everybody's input and insights. Really appreciate it.
Okay, great. Today, I'm excited to share how Inox AI solution can save vision for millions of people with diabetes. It is well known that over 30 million Americans have diabetes. What's less known is that nearly 30% of them have diabetic retinopathy, the leading cause of adult blindness. DR costs the country billions of dollars annually. Well over 200,000 Americans are blind due to DR. Although DR-driven blindness is preventable and early detection is key, the traditional testing approaches are just not working. First, for dilated ophthalmoscopy, patients have to wait months to see an ophthalmologist, plus human examination is prone to miss diseases. Second, although patients' eye images could be sent to a remote ophthalmologist for reading, this approach does add waiting time for human reading, plus human misses are still very possible. Our iArt AI technology is about to transform the DR detection process. With AI now can do the reading, primary care and diabetes care doctors can prescribe this test in their offices. Operators with high school diploma can take images and print out the AI diagnostic report on the spot. Now, does AI work? Our iArt AI technology has been validated extensively and is performing at high level of accuracy. In our prospective multi-center clinical trial against the rigorous gold standard, iArt detected referable DR at 96% sensitivity. It is worth noting that human exam only achieve about 27% sensitivity when compared with the same gold standard. These results enable our iArt technology to be the only FDA-cleared autonomous AI technology for detection of both referable DR and the vision-threatening DR. Now, over the last 11 years, our company has achieved many milestones, eventually now in front of clinical adoption in the US. We patented our IP, published pretty strong validation results in multiple countries, secured FDA clearance, and received a brand new CPT code about a year and a half ago. iArt's clinical role is now accepted by various clinical guidelines, including diabetes, ophthalmology, telemedicine, and HEDIS. Reimbursement is now approved and accepted by Medicare, Cigna, as well as Anthem. One of our projects in Europe is supported by the World Diabetes Foundation and recognized by WHO. As a result, IR is adopted by a growing list of IDNs, ACOs, as well as physician practices, reaching about 70 test locations in US and Canada now. So why are all these relevant to Cigna? This is relevant because health plans are struggling to improve quality measures for the diabetes eye exams. Actually, in 2017, less than 60% of Medicare beneficiaries with diabetes had an eye exam, which exposed about 15 million Americans to the risk of losing their vision. Significant health disparities in diabetes and DR also contributed to this challenge of closing the HEDIS-related quality gap. The hardest hit population include American Indians, Hispanic, Black, poorly educated, rural communities, especially in Southeast, and older people. The IR solution can improve DR-related health equity by improving access, reducing bias, providing real-time results with improved accuracy. So actually, we can help Cigna to improve its quality measures for diabetes eye exams. To make that happen, first, we'd like to work with Cigna Medical Group in Arizona to demonstrate IR's clinical and economic value. And second, we'd like to work with Cigna on the national awareness campaign for IDNs, ACOs, and providers. Third, we can actually support supplemental testing activities in alternate settings, such as patient homes, communities, workplaces, to reach diabetes population not well penetrated otherwise. So in summary, why should Cigna work with INOC? Cigna can partner with INOC to improve its quality measures, save vision for Americans, and also access additional AI technology that INOC is working on, supported by multiple NIH grants. So with that, I'd like to thank Dr. Jeffrey Klein for his guidance to my project. I'll be happy to answer additional questions.
Thank you, Frank. If you could stop sharing your screen. Fantastic. Judges, rejoin us. There you are. All right. Any questions for Frank?
Can you explain the cost model? So this is a tool that goes to providers, and then who pays?
So the provider who gets the reimbursement from payers, including Medicare, actually buys our system and also pay for the AI per read. Okay, so there are simply just two cost components, Audrey. One is the fundus camera itself. Okay, so it's either a one-time purchase or it's a monthly lease from us. Okay, for the equipment. The second is AI per read. It's like doctors per read, right? So here in our situation, AI is doing the reading. So we do charge, a AI reading fee per patient. Okay, once again, two cost components: camera hardware and AI for reading.
And where do you see our role as a payer?
I think awareness is a big deal, right? So no health plan across the nation is doing well in this measure, in this quality measure, right? So as I said, right? So you do have a lot of influence over ACOs, physicians, and IDNs, right? So we would love to work with you, work with the people that you provide coverage for, right? In order for them to not only just to consider our tool, but more importantly, be aware of this challenge and be aware of some of the best practices that is going around the country now to improve this quality measure, right? The other thing is, certainly I'm aware that you do have your, Cigna medical group, so, as maybe that's an excellent idea also just to start to look at, yourself, whether, we can provide the desirable value to your operations at the Cigna medical group. Then thirdly, if we think about the community at large, right? So even go beyond HCP's, kind of setting, and look at alternative settings such as community-based, home-based, and the workplace-based kind of testing as well.
Thank you.
Thank you.
Along the lines of costs, I guess, like how much volume does a provider need in order to kind of offset the initial cost, upfront cost, but also the ongoing cost of your device? Against
today's reimbursement, just so you know, Medicare decided to pay for our new CPT code at about $55 per test. Okay, so with that in mind, and also assuming health plans are at least doing that kind of level or more, we estimate about 300 tests per year is needed for a diabetes center or primary care clinic to sustain, in other words, to not lose money, right? To potentially even, have a little bit left over as well. So yeah, about 300 patients per year, Nicole.
Do you see any hesitancy on the provider side for a tool that only has an AI read, especially around like liability, if the provider doesn't really know how to read it themselves or can't?
That question very seldom come up, just because we are FDA cleared the device to do this, on the spot automatic diagnosis. We actually carry product liability insurance to stand behind any malfunction of our AI, right? So we shift the liability certainly the PCPs or the diabetes center who are the user, they're not liable for any reading kind of related liability, right? Nor there's another doctor here needs to shoulder any kind of liability burden. The party that shows the liability burden is basically our product liability insurance.
Okay, thanks.
Yeah.
All right, any last questions for Frank and Inuk? All right, I will ask all of you to go off camera. In honesty, we know how many competing priorities everybody on this call has for their attention, and you spend a lot of time with us today for a very, very, very important and we think an important cause and an important matter. So on behalf of Matter and my team, I'd like to say thank you to the judges. That was really great. Thank you to the startups for, putting up your best foot forward, and for, of course, all of the Cigna teams. And I will pass it over to the coolest innovator to ever wear a bow tie, James, for some closing remarks.
Thanks. I should have wore a bow tie today. I didn't. No, thank you, Sabrina. And thanks to the Matter team for making today possible to run as smoothly as it did, and even run ahead of schedule, which is always incredible. So a big shout out to you, Sabrina, Priyanka, Sam, Gina, for making the today work well, and again, the whole program from when we began this back in before the 4th of July in the late spring. So thank you again. I will reiterate or sort of repeat the thank you to the judges today who sat through this or will sit through this, the presentations and listen and ask great questions. So thank you all again for giving your time. I'd like to thank all the startups for their dedication. As was mentioned, a lot of time and energy, not only today, but over the last month or so, working with our teams to really pull together what I thought were very impressive presentations. All great, all really interesting, all tackling different aspects of the challenge that is diabetes. So thank you to all the startups. Also like to thank again all our mentors. We had each startup company was assigned a specific mentor who was able to help and guide them over the last 4 or 5 weeks, and want to thank them. A little bit of what's coming next in the program, as was mentioned at the top. The judges will be over the next several days making some decisions about which of these 12 will continue in the program. We'll narrow that list to 4 to 6 who will continue for another round, whereby they'll start to shape what programmatic effort in partnership with Cigna may look like. We'll be announcing those winners the latter part of next week, latter part of next week, and then we'll eventually name some winners. The program will continue through mid-December. I do want to thank all our audience for taking part today, and I hope everybody has a great Thursday afternoon and a great weekend. So thanks again.